Great. So our next presenter is going to be Dr. Cassidy. And Dr. Cassidy is an associate professor at Western here in the Department of Physical Medicine, Rehabilitation, and Pediatrics. She is going to be speaking today about transition to adulthood, and her main clinical focus is in the Transitional and Lifelong Care, or TLC program, housed primarily at Parkwood. And it provides a long-term rehabilitative care to patients with chronic and sometimes complex conditions of childhood onset, including cerebral palsy, spina bifida, and others. And she also, as a physiatrist, does EMG studies for us, which we need. And then she also has a specialty teen clinic at the Thames Valley Children's Center, and inpatient coverage of the musculoskeletal rehab unit at Parkwood. Her research interests lie primarily in long-term outcomes among people living with chronic conditions of childhood. Dr. Cassidy.
Thank you, Dr. Gillis. Okay, that was such a thorough introduction. Thank you very much. I'm really excited to chat with you guys about transitioning to adulthood with a developmental disability. And I'm interested to hear lots of different perspectives because I don't think that there's one right way to think about doing this. This is not something where there's a lot of evidence to tell us these are, steps A, B, C, and D that must be taken. There's a lot of general thoughts and guidelines, but lots of room for interpretation and lots of room for sort of flexibility and unique planning for unique patient situations. So I hope we'll have lots of opportunity for discussion. So I thought that I better introduce myself, but Dr. Gillis did such a great job, but I thought that you might want to know a little bit about why I think I know something about this topic, and that's largely because I work in the Transitional and Lifelong Care program. So it is a program that started in 2014-15, and it is essentially a program for patients who have special healthcare needs that are related to a condition of childhood onset. I'm a physiatrist, and therefore our patients have physical disabilities, but many of them also have developmental disabilities. And it was intended when we created it for transitional orphans. So it was very much meant for people who didn't have a clear destination in adult care. So that means that, for example, we don't tend to see people with acquired brain injury because there was already an acquired brain injury program, but there was no program for people who were adults transitioning to adult care with cerebral palsy, spina bifida, and other developmental disabilities. And so that's who comes to see us. We see adolescents and up. We don't have an upper age limit, so our age range is from about 13-ish to, I don't know who our oldest one is anymore, around 80, something like that, so quite an age spectrum. And I mentioned there are most common patient populations. And we share many patients with the dual diagnosis program in adult psychiatry because many of our patients, of course, have developmental disabilities that require their services as well. Where do I point this? Okay, good. And then I just wanted to understand a little bit about who we have here. I already got a little bit of an update on that from Sarah. So it sounds like we have quite a spectrum of primary care, and I'm including obviously online as well. Primary care providers, pediatric psychiatry, maybe nursing staff, maybe physio, maybe psychology, students, speech and language. So I won't make you all put your hands up. I just wanted to kind of know who I was talking with, and I'll try to tailor my comments to be fairly broad that way as well. Our objective, so by the end of this session, I'm hoping that our participants will be able to describe some of the challenges encountered by people with developmental disabilities and their families as they transition from pediatric to adult care, and also be able to enact strategies in your own professional practice to ease transition and identify resources that may facilitate that. We're going to start with the first one. So I just wanted to make sure we're all on the same page from a definition standpoint. And I think this is really important for us to think about conceptually. What's the difference between transition and transfer? So transition has been defined in a number of ways. This particular definition describes it as a purposeful, planned movement of adolescents with chronic medical conditions from child-centered to adult-oriented healthcare. And that, you will see, is very different than the definition of transfer, which is just the shift of responsibility of patient care from pediatric to adult care settings. And perhaps many of you will be familiar with the concept that transfer happens all the time, whether we want it to or not. There is like a real reason why that happens with a set cut point, usually around 18 or 21, potentially on where you work. But transition does not happen all the time and often does not happen well. So, this is the one that happens whether we want it to or not. That's the transfer. And this is much more variable. Often, I think this was important for me, and considering that lots of different perspectives might be here in this room today or online. Often transition is viewed specifically from a medical specialty lens, and a lot of the literature on transition focuses in on that area. However, in an ideal world of universal primary care, there may not ever actually be any transfer. If everyone had a primary care provider who knew them through childhood and continued to know them through adulthood, there may not actually need to be a transfer, but that doesn't mean that there doesn't need to be conversation around transition. Because of course, that transfer from pediatric to adult care from a primary standpoint is only one small aspect of their overall transition as they're moving from childhood to adulthood. And so I think we just need to think about it more broadly. Also, of course, many of our patients have no primary care outside of pediatrics. Many of these people who have any issues with complexity or developmental disability have their primary care provided by a pediatrician. And so that person's not going to be involved long-term, unfortunately. And too often these patients are simply discharged from specialty care with the sort of blind expectation or hope that primary care will pick up and take over. And there's a reason why that happens. We'll talk about that. It's obviously not ideal. So again, that just takes into account the medical side. Transition of other services like physio, OT, speech and language, social work, and other health services is a whole other kettle of fish. In Ontario, our patients transition out of school-aged home and community care services and into an adult-based home and community care portfolio. And so that's a whole other transition that they're experiencing while they're transitioning their medical services as well. So why do we do this again? Things are going so well in my pediatric bubble. Why would I want to transition at all? There's a lot of arguments that maybe it would make sense sometimes for people to stay in pediatric care, but that's not globally feasible. And so there's also a lot of reasons why it makes sense for people to transition out of their pediatric bubble. So pediatricians and pediatric facilities are only designed to manage pediatric patients, and there's a lot of sort of legislative and reality type situations that go and underpin that. So training constraints, facility and capacity constraints, provider licensing restraints. There's a lot of reasons why pediatricians and pediatric providers can't keep their patients forever. Adult bodies experience adult medical challenges, and so that's a reality that we have to deal with as well. And it may not make sense medically for people to stay under the care of a pediatrician if they're going to start experiencing problems like adult onset diabetes or hypertension, cardiac issues. We're going to hear later about more memory issues with aging. All those things may not be reasonably managed within a pediatric sphere. Also, adults with developmental disabilities have changing needs as they age, which are medical and non-medical. And staying static in a pediatric care bubble sometimes doesn't address that completely or adequately. So that all sounds great, but that obviously does not make it easy. So we're going to talk about why it's hard. So there's lots of barriers to transition, and a lot of the literature about transition from pediatric to adult care focuses in on these barriers, and that's a good and a bad thing. It's good because we need to know what the problems are so that we can try to address them. It's challenging because there's often not a lot of solutions presented, but that leaves opportunities for us. So system challenges are probably the most numerous, and many of these will sound familiar to you, I'm sure. So adult programs often have eligibility criteria that don't line up with the conditions that patients have that we're talking about. Again, we made the TLC program because they were orphans. They didn't fit the criteria for admission into adult programs that were already in existence, and that problem exists elsewhere as well. There's often a lack of equivalent services with knowledgeable adult providers. We hear this a lot from patients and their caregivers that, they might be able to find X type of provider, but X type of provider has actually never worked with anyone with cerebral palsy before. There's a lack of training and education in chronic childhood conditions, especially amongst our adult providers. I'm allowed to say all this stuff because I am an adult provider, so I feel some immunity in calling out myself and those around me. So a lot of adult providers will say things like, this wasn't in my job description. I became a whatever type of provider, and I was going to take care of X, Y, and Z problems. That did not include these childhood conditions. There's a lack of clinical guidelines for how to manage these patients, and so even if you find an adult provider who's willing to take them on, there's not a lot of research for them to fall back on and say, okay, I know what to do. There's often a lack of recommendations from pediatrics about what to follow up and what to expect. That's going to come up in the next slide about communication barriers as well. insufficient community resources once they're discharged from peds. So this came up in a specific survey that we did of adult physiatrists. Why don't you see more patients who have these problems? You have the skills. And they said, yeah, I have the skills, but if what I think the patient needs is a physiotherapist and an occupational therapist, and there are no providers or access to those services, then why would I see them? I can't make any meaningful impact. Lack of service coordination or one central place to call. This is something that patients report a lot. When they were on the pediatric side, they knew who to call. And I often fall back to Dr. Frid on my example of Dorothy, who worked at TVCC for such a long time. And she was the nurse who worked in the CP clinic and the spina bifida clinic, and everyone knew that they could call Dorothy no matter what their problem was. Didn't matter what it was, Dorothy would either answer it or she would direct you. And it's hard to find that same service on the adult side. Often the facilities on the adult side are developmentally inappropriate. So you get admitted to adult care and you're a 42-year-old who's nonverbal with cerebral palsy, and you get admitted to a 4-bed ward with 3, 75, 80, 85-year-olds. Someone's got a broken hip, someone's in with their whatever. It's a very difficult setup on the inpatient side for this patient population. Insufficient insurance coverage. We think we're immune to that in Canada, and we obviously are not. Anyone who works in the system already knows that that's true. My American colleagues are shocked usually when I tell them things about not being able to pay for physiotherapy once you get to the adult side. Adult providers describe a lack of remuneration and administrative support to get involved in this type of care, and this is for sure a real concern, because if you get paid the same fee to see someone who's going to take you 10 minutes and someone who's going to take you 105 minutes, there's not a lot of incentive financially for adult providers to engage in that. And then just in general, there's not enough services to go around. And so I always like to, just to defend my adult colleagues a little bit. If my adult colleagues are trying to figure out what services they're going to provide to what types of populations, this is the little diagram of all the people who have diabetes or heart disease in Canada compared to the people who have CP or other developmental disabilities. There's just so many of the people who have heart disease and diabetes. So people put all of their eggs in that basket to make sure that they're serving such a large swath of the population. But that doesn't mean this little section doesn't need us to. Communication barriers are important. So we talked about this a little bit already. So insufficient communication between pediatric and adult providers. So something just as simple as you can't get the documents. So even I work at Thames Valley, and then I see my patients over at Parkwood when they turn 18, and whatever notes they had at Thames Valley are now lost to me unless I get a physical copy of them and bring them over. And I work in both sites, so I can do that. But that means that whoever else is seeing them on the adult side can't see any of those Thames Valley notes from before. And then insufficient communication between the adult providers and the patients and families. We hear this from our patients and families a lot about how they show up to their adult appointment, it lasts 10 minutes, they don't know what got said, and nobody talked to them directly. They might not talk to the patient directly, which is of course inappropriate, or they might not include the caregiver because they're used to providing patient-centered, not family-centered care. And so then the caregiver feels like they don't know what's going on anymore. So what do adult providers have to say for themselves? I thought this was just so interesting. This was an informal survey that was never published by a sort of transition guru in the States named Dr. Cooley. So this was in 2014. He did a survey of adult primary care providers in New Hampshire, and 46% of them said they rarely or never received any transition summary or call from a pediatric primary care provider. So that they described that was a real barrier to them picking up or becoming involved in a significant way in the care of these patients. They felt more comfortable with things that you might expect them to feel more comfortable with because they learn this stuff for adults. They learn about asthma, they learn about hypertension, they learn about mental health, they learn about diabetes. Many of our adult providers don't learn anything about cystic fibrosis or about metabolic disorders, autism, or those who are technologically dependent for care. They said that it would really help if they got a written summary, if they had more specialist support, which is where I hope the TLC program comes in for us locally. I hope primary care providers feel more comfortable being primary care providers because that's all we're asking them to be, not the everything for these patients. A direct conversation with the pediatric provider would help, and also just written info about the condition. They're taking care of so many people who have those common conditions, and they're working so hard to stay on top of the literature for diabetes, for example. They may not have time to do a deep dive into this unique metabolic condition that only affects one person in their practice. So if the pediatric provider who knows a lot about it can just give them a one-pager, then that would be really helpful. On the patient and family side, fear of leaving the supportive, familiar pediatric team is real. This is a team that has supported them, kept them alive, peer-led for them all the way through, and it is scary. And the adult team is unknown and totally different. Resistance to differences in care plans recommended by adult providers is a barrier both for the patients and for the adult providers. I will say I have seen that a lot as well. So if they have a care plan from the pediatric team, then they meet their new adult provider, and the adult provider's like, that's not how I think we should do this, and they come up with a new plan. There's a lot of friction that creates very early on in that therapeutic relationship. Often the patient or family may have negative beliefs about adult healthcare providers and concern that adult providers will fail to recognize family expertise, and there's a reason why they fear that too. On the pediatric side, a lack of comfort addressing adolescent and adult issues is definitely a barrier. And so things that have come up, and I remember having conversations about this as well, about when is it time for patients to leave the teen spina bifida program, and one of sort of the joking responses was when they become pregnant. And that speaks to the fact that there's a lack of comfort potentially on the pediatric side when those more adult issues start to arise. It's actually a good reason for us to start thinking about transitioning them over, but not just transferring them. We can't just kick them out the door in their hour of need. We need to have a planned transition. Pediatricians, patients, and families are sometimes hesitant to let go of their ongoing care. Okay, so that was a lot of reasons why it's hard, but we've also said that we have to do it. And so how can we facilitate a successful transition? We're going to look at our second and third objectives to enact strategies in professional practice and identify resources. The first thing that comes up then is, what even is a successful transition? If we want to make a transition successful, how do we even define that? What is success? And it's a great question, actually. The literature doesn't really tell us. So there's a lot of debate in the literature about how to look at outcomes related to transition and what kind of metrics we should be looking at, partly because there is no one outcome you can look at that would span across populations, right? So some studies have looked at things like adherence to medications and attendance at scheduled appointments, like do you actually show up on the adult side after we plan to send you over there? Disease-specific indicators, if that makes sense, so things like HbA1c for diabetes, rates of hospitalization, patient or family satisfaction, and transition readiness or ability to self-manage have all been outcomes that have been looked at in the literature, but no consensus on whether or not those should be broadly applied. Specifically in intellectual and developmental disability, there have been some suggestion that other things that should be included might be things like, are we maximizing participation across life spheres? Are we looking at a functional role in society that's reflective of a person's capabilities and interests? Are we achieving that if we're successfully transitioning to the adult side? And where possible, are we achieving independence and self-care? And so you can imagine, again, this is actually kind of a nice thing for me because I'm seeing here that in the literature, we're not just looking at medical specific things, we're looking at things that span across the important elements of an individual's life. So the Canadian Pediatric Society has a position statement about what we should do to transition people to adult care, so I thought we would go through the elements of that. So they suggest that there are 4 core components for successful transition. Number 1 is that it should start early. Each individual should have a unique transition plan. We should provide support before transition and provide ongoing support after transition as well. So we're going to just talk through those 4 elements. So in the start early sphere, one of the things that they talk about is assessing transition readiness with both patient and caregivers. And there's a lot of different definitions for transition readiness also. And so we're going to talk about that in a little bit. They suggest considering a youth's potential for self-management and individual goals, which might include things like activity, education, recreation, and vocation. And so again, you can see the importance that's being placed here on not just looking at the medical, but looking holistically at a whole individual. Because of course, transition is not just medical. And most of the time, as we said, they're transitioning their medical care, they're transitioning their allied healthcare services. They might be looking at transitioning out of their familial home. They might be transitioning from high school to university or college. They might be looking for volunteer opportunities or employment. So many elements of their lives are in upheaval. And if we just look at one sphere, we have totally missed the boat. Is there such thing as too early if we want to start transitioning early? The research does not actually seem to suggest that there is a too early. But all this research is based on very small numbers of people providing, interview responses or things like that. Because again, we don't know what outcomes to look at. So And we also don't have a lot of great transition programs in place that we can evaluate for effectiveness. So this is really based on sort of individual experiences or family experiences where they have reported when it would have been nice to start receiving information about transition. So there may not be a too early, but practically there might be a too early because there's so much going on in those early years. And our pediatric colleagues are doing such a good job of supporting appropriate health and growth and development. You probably don't have time to focus on what's going to happen, 15 years down the road. But 18 and a half is too late, that's for sure. So some of the literature is more in the realm of what about 12 to 14? Can we start to lay some groundwork? Can we start to think about what that might look like?
In that situation, Caitlin, you're talking about working with the family specifically to plan for that?
Depends.
Because I think that I can start planning transition to adult services for somebody when they're 16, 17, but a lot of places won't accept application forms or referrals until somebody's 18 or just about 18.
Yes.
So what do we do in those situations?
So that speaks to all of the elements of transition, right? So you're talking about things like applying for adult funding programs or applying for adult services.
Programs, yep.
Yeah. So that's a specific sort of stage of transition planning, but early transition planning doesn't have to actually be those applications. Early transition planning should be a conversation, right? Like this is what's gonna happen as you're approaching age 18. Some people don't even know. Like some people don't know that they're gonna lose their long-term providers, right? They've never conceptualized the fact that this person only provides care up until 18. And so those really early conversations are not hard and practical, they're much more conceptual. So we talked a little bit about assessing transition readiness. There's a number of scales that are available to do this. This one is called the Transition Q. It's available from the Kill and Child website, which is a Canadian group in Hamilton that does a lot of research on childhood disability. It is research supported, and essentially this is looking at a bunch of different things about you and your own interaction with your healthcare. So this is very, I'm gonna call it medical sphere in terms of the transition, and very focused on people who are expected to achieve some degree of self-management. So a number of our patients would never be expected to call and make their own appointments if they are nonverbal and dependent on their caregivers for that, right? So obviously this would only be relevant to a certain subset of our population, but it may be helpful for people who have some of these skills or may not have them yet, but might have the potential to develop them. So enacting a tool like this might be really helpful in the pediatric side to say, here are some areas that we can actually start working on. And that might be part of your early phase of transition planning. So you've had those conversations starting when they're 12 or 13, maybe a lot of that is directed to the caregiver, some of it directed to the patient. As they're hitting sort of 14, 15, 16, maybe you start looking at some of this stuff and say, well, why don't you answer your doctor's or nurse's questions on your own? Can we work on that? Maybe in your next appointment, we're gonna do half of it by yourselves and half of it with your caregiver present. So you can start to use this as a tool to actually enact transition care strategies in your early management. This is just another one. This one is American. It's called the STAR-X Transition Readiness Questionnaire. So very similar things that you'll see on here. How often do you make your own appointments? How often do you take your medicines on your own? Very medically focused. Transition readiness measures, as we said, are not for everyone. Not everyone is expected to achieve self-management. Some of the questions may apply, others may not. What I really like about the STAR-X transition questionnaire is that it actually has a parent version, because I think we miss the boat on some potential intervention for parents and caregivers if we say, well, this patient's not going to achieve self-management, we're not going to use any of these assessment tools, when actually, if the patient's not going to achieve self-management, the person that we might need to prepare for transition more might be the caregiver, because the caregiver often has quite a culture shock when they transition over to the adult side. And so if we start to look at some of the caregiver spheres, that might be still really helpful. And of course, each patient is unique and demands unique consideration. And so none of these things can probably be slapped onto every transition plan, especially in a sphere of people with developmental disability, but some element of them may be useful. And as we said, they may be helpful to identify targets to try to address on the pediatric side and to consider continuing to work on it in adults, or identify areas of less strength that will continue to require support long-term. Create an individualized transition plan. So this is sort of that second step in the CPS guidelines. One of the things that they feel is very important, and I couldn't agree more, in a perfect world, this would actually exist, is identify a transition champion. So it's really nice if you can find one person who's gonna drive the ship, right? Someone who's gonna be in charge, someone who's gonna say, you know, have we looked at whether or not you take your own medications? Have you talked about what it's gonna look like on the adult side? Everything goes smoother with a quarterback. Unfortunately, most programs don't have access to that individual who's able to take on that role. But we know that it's important. And so if this is a population that you work with regularly, it might be worth thinking about either how you can step into that role in some ways, or how you might be able to partner with others and share the role. We want to address gaps in transition readiness and confidence, and flexibility is mandatory. So this is why this plan has to be completely individualized. The level of support required will vary dramatically. You might have a policy about age, but it might need to change if your patient is unstable or not ready to transition. It makes a lot of sense for them to just walk out the door when they're 18, but if they're in the middle of 7 medication changes and they just had a surgery and they need another one, then there has to be some flexibility institutionally as well. Whether you're targeting your transition plan primarily to the youth or to the caregiver needs to be flexible. It's just like we said, again, the caregiver is the one who might need more of this education if they're supporting a loved one who has more dependents. Oh, and what you'll discuss will also be affected. So things like, do you need to have a power of attorney, or do we need to look at establishing guardianship or something like that in someone, again, who's not capable of making their own decisions? Primary care involvement is crucial. This is like a soapbox that I live on. Primary care should be involved early to improve continuity of care, communication, opportunities to educate about needs specific to each condition, and then chances of having a quarterback. Because ideally, the primary care provider is the quarterback. Not all of our patients have primary care providers. Not all of our patients who have primary care providers have regular access to them. Not all primary care offices are accessible for people who have physical disabilities. So there's a lot of challenges in this. But if we think of our ideal world, it'd be so great if everyone had that primary care person who would not actually have to do a transfer, right? When we're talking about that transfer versus transition, they'd have to consider the principles, but there would be no handover there. And there is actually good evidence to support this. There's so little evidence about any of this stuff, but there is actually evidence to suggest that in some conditions, and presumably generalizable to most conditions, people do better if they have access to a continual primary care provider throughout that transition sphere. What's another great support for this? So a primary care provider who's continuous, that'd be a great support for this. One of our goals for this lecture was to talk about real, actual, tangible resources that you could use. So the Community Services Coordination Network is a service that is in use particularly by people with complex conditions, but also specifically by people with developmental disability. And so this is an organization in Ontario that coordinates access to various services and supports for adults with developmental disability and children and adolescents with complex needs. One of the greatest services I think that they provide is the coordinated service planning. And so and annoyingly, it has 2 acronyms. So the coordinated service planning is the CSP, which provides families with an SPC, a service planning coordinator. But these can be invaluable supports for families, especially if they're trying to navigate, you know, I'm transitioning funding, I'm transitioning schools, I'm transitioning doctors, I'm transitioning physio, all of these different people. And especially if they had, you know, 7 specialists involved on the pediatric side and which specialists are going to be involved on the adult side. There's a lot of different things to try to coordinate. This becomes a full-time job for families. And the CSCN can provide some really, really helpful support there. They're not going to make up a new plan if they can't find you a neurologist if one doesn't already exist, but they can help to make sure all of those pieces are lining up and identify where there might be gaps. The next step was to provide support before and during transition. So this includes things like educating and providing peer support when possible for youth and caregivers. Pediatrics should create a health transfer summary and or recommendations for management or surveillance and provide it to youth and to clinicians. This is in the CPS statement. I realize that this is maybe a bit of a high goal for us to try to achieve, but it is so helpful when it occurs. So as someone who works on the pediatric side in the Thames Valley Children's Center in a clinic with a nurse who's wonderful, her name's Kaylee, I don't know if she's listening, but every time I see a patient with CP, I have this whole document and she's gone through a whole bunch of documentation from the chart and populated, you know, they had this surgery in this year, they had this surgery in this year, these are their current medications as far as we know, here's some issues they've had in the past, and here's what I know about their current concerns. That makes such a difference to me, and it makes such a difference to the patients when I walk into the room knowing a little bit about what their story is, so that they don't have to tell the whole thing with every detail from day one. I don't know if anyone's familiar with My Health Passport. Anyone in the room, have you heard of that before? Click on it. It is a hyperlink. Can I use this? Okay, great. So My Health Passport is also an Ontario initiative. It came from Sick Kids. It was developed by Miriam Kaufman, who's a retired adolescent medicine provider. And essentially, it's this website. If you type in My Health Passport, you'll find it. And they have these sort of pre-made things where people can go through and populate information about themselves, or the provider could populate information about a patient that they're treating. The one that I have open here, I can't remember it. This might be generic developmental disability, but when you go on the website, there's a drop-down menu and there's a My Health Passport for probably about 30 or 40 different conditions. So if you have a specific condition, you can go click on it. If you've just had a whole bunch of orthopedic surgeries, there's an orthopedic surgery one. If you have cerebral palsy, there's a CP one, there's a spina bifida one. And so you can either guide your patient to do this, you can maybe work with your patient on doing this. If they're working with an occupational therapist or physiotherapist through their school, maybe that person can help support them in doing it. There's a lot of different ways that you could potentially work through it. And then they have this as sort of a document that they can refer back to. They can print it out. It prints out on this like really tiny piece of paper so that they're told to keep it in their wallets so that they can bring it with them. If they go to the emergency room, for example, it might have a record of their medications. That's how up to date they keep it, how helpful it might be. But you can also imagine that that might be really helpful to the adult provider. I'm picking up care from this patient, for this patient. And if you as the pediatric provider have had any involvement in making sure that this got completed, then that's really helpful to me. Pick up and move on. So that's another resource that you might enjoy. And then adult providers should start preparing for their new role, more active in driving the medical piece as opposed to more receptive. So this is something that can be taking place during that transition as well. Love when this happens during an overlap clinic. So this is what I do at Thames Valley. I go to the pediatric clinic as the adult provider, and I'm the only adult provider that patients see when they're there that day. So they see all their other pediatric people, whoever they need to see, and they also see me. So they see all their familiar people. I'm the only new face. And when I first meet them, what happens is a lot of their stuff is still done by their pediatric person, and I'm just there to kind of say hello, familiarize, talk a little bit about the concepts of transition. The next time they come to their appointment, the pediatric provider is just kind of there to be like, hello, I'm stepping out, and then I take a more major role. And so this is me becoming more active and involved and driving the care as time goes on through their transition. Thank you. This was just an example. I took this right off the TVCC website because one of the things that was suggested in this step is education and peer support. Peer support's a hard one, and we're working on this in the TLC program. It's really difficult as an adult provider, especially unless we have our own made locally peer support programs. It's hard to hook people up. From a privacy standpoint, it's hard to just give out patient names. Like this person might do really well talking to this person, but it's challenging for me to get permission from everyone to share information. It's just not an easy process. But I thought it was really interesting to look at the Thames Valley website and see some of the supports that they already have available for anyone who wants to participate in them, who's a TVCC client. Yeah. I think that's what I wanted. Oh, the other one that's on there is, it's called On Track, that link that's on that one. Maybe we want to click on that one too. Sure. I'm just trying to make sure you get some resources when you leave here. So On Track is another Canadian developed program out of British Columbia. And they have all of these things on here, again, as we're trying to provide some education, we're trying to prepare for that transition. They have this whole thing that's called the On Track Youth Toolkit. And they also have a family toolkit you can see in this sort of drop-down menu on the side. And there's all these different sort of categories that you can click on that are kind of like a more detailed version of the My Health Passport. So they can go through and fill out a couple of documents that say like, here are the medications I take and why, here are the surgeries that I had and what they were for, here's what happened when I took this medication, it was a bad idea, please don't ever prescribe it again, that kind of stuff. And there's very importantly, stuff that's on there that is not purely medical. It's about making connections socially, it's about their interests and how they'd like to see things develop over time. Thanks, Sarah. Another resource to guide us as we're navigating through the transition, I thought this one might be of interest to the primary care providers in the room. Great resource available through Surrey Place, which is an organization in Toronto. They have a great link through their website where you can click on guidelines for the care of the adult with developmental disabilities. And there's a ton of recommendations. I highlighted here and copied the ones that are related to navigating the transition. But this is a huge document that basically goes through a lot of different considerations that you might want to, talk about with your patients when they come to see you as their primary care provider when they're on the adult side. Again, one of those barriers that's been identified for adult providers is that there's no guidelines. And in many situations that's true, but there is this set of sort of general guidelines that you can use in the global developmental disability. Another resource, of course, is Developmental Services Ontario, which is the access point for adult developmental services funded by the Ministry of Children, Community and Social Services in Ontario. So this is sort of an umbrella organization that serves people who are adults, so they have to be 18. They have to have a developmental disability. And unfortunately, they don't just believe me if I tell them they have a developmental disability. They need to have a neuropsych test completed, which might have been done in school. And if they have a static condition, then they will accept documentation from school. Otherwise, if they don't have any documentation, then DSO will put you on a list to receive publicly funded neuropsych testing to make sure that you meet the criteria for service. And then you have to live in Ontario. They have a number of funded programs. So the Passport program is the one that we talk about with our patients most often. So this is something that they can access to support community participation. They also have specialized support like adult protective service workers, behavioral consultants, etc. They run a number of wait lists for housing services. So this is something that we talk about with our patients and families as well. Is there a time where they might be moving out of the familial home into a residential care facility? DSO is someone they need to talk to about getting on wait lists for appropriate placements. They have supports for community participation and for respite services, and they partner with all sorts of organizations all over Ontario. So these are some of the ones that are local here. So Community Living London, Alice Sadi, Participation House, Hutton House, L'Arche, the Leeds Employment Service Program, Family Services Thames Valley. These are all organizations that partner with DSO so that if someone has a developmental disability and has applied for and been approved for DSO supports, then they can access services through these agencies. I feel like my formatting went funny when it transitioned to your computer, but you can still read it, hopefully. So that last step was to ensure ongoing support during and after transition. So we want to ensure that youth attend their appointments. This is definitely something that comes up in the literature. We haven't really done a great job transitioning people if they never show up to their adult appointments. So that is one thing that's potentially a marker for outcomes in transition. We want to continue to involve caregivers as per the youth's wishes and potentially gradually wean that over time if it's appropriate. It's very important to discuss with these individuals their right to privacy in their healthcare, but also appropriately involve caregivers as needed for decision-making supports. And then we want to make sure that we consider all spheres of health. So, we've talked a lot about sort of the medical side. I wanted to give the example that many of our patients on the TLC program express gratitude for being able to talk about something like healthy sexuality openly and safely. And this is obviously very important, not only because the risk of sexual abuse in this population is very high. And so this is something that sometimes isn't brought up as something that can be openly discussed in pediatric appointments, but it's something that we do try to make an effort to make sure that they can openly discuss in their adult appointments. So those were our objectives. Hopefully we've covered them. I just wanted to say a couple of things about, a few little nuggets about what I see and do in real life, because that's a lot of talk and talk and talk. In real life, we see people with multiple different diagnoses at multiple life stages. So people come into the TLC program either directly through pediatric transition, so where we have those nice overlap clinics, but actually the majority of patients have come into the TLC program as referred in by their primary care providers when they're already well into their adult years. So we're taking over care when they've not seen a specialist, sometimes for decades. We do notice that transitions happen repeatedly before and beyond high school. So transition is not a unique individual time point. It's something that happens over and over in different spheres of life. The major challenges that we identify through transition include a mix of medical, social, and environmental issues, and we don't get to pick the timing of medical challenges. It would be really nice if medical challenges only arose when we weren't also dealing with financial or school or environmental transition, but that is just not the case. And so we have to be kind of ready to adjust our transition planning depending on how their medical stability is at the time or other factors. Common challenges, it's difficult to get useful information about the past, except for when Kaylee gets it for me. Either there's no way to get it, I can't find it anywhere, or it spans multiple volumes. And so that's usually almost unhelpful completely to me because I can't look through, volume 1 through 7 of 7. We have limited resources, so there's not enough of us or anyone else. So this is not unique to us, but perhaps is a little bit more of a squeeze on the adult side than it is on the pediatric side. And there's often a gap in services with handover to adult community service providers and funders. So we often are challenged with our patients who we are seeing through that sort of pediatric to adult transition where, yep, we're there, so that's great. But maybe they're experiencing a gap in funding because they didn't apply for DSO right away, they lost access to their respite funding, and now there's no one who's available to help in those 3 hours when they're home from school and parents aren't home from work yet. So that's a real challenge for us. And then the other thing, of course, is that behavioral changes, maybe medical or maybe truly behavioral. We see a lot of behavioral changes in this population, especially as they're going through stressful transitions, right? This totally makes sense to everybody who works with people with developmental disability. They may have medical problems or they may not, and that's often very difficult for us to sort out. I don't know how much time we have left.
Lots.
Lots?
Yeah.
Okay, I talk fast, so I counted on it.
People listen too slowly, you don't talk.
Thank you, you understand.
Yep.
So I was curious to just sort of open it up a little bit for a discussion about what either online or in the room, what you guys see and experience, what challenges you're worried about, what solutions you've found, what solutions you haven't found, because maybe some of us in the room have other suggestions for you.
So how do you cope with institutional sort of policies that aren't flexible around changes? So one example that comes to mind immediately, I have a patient I used to see with, she has tuberous sclerosis and fairly, sorry to say severely, profoundly intellectually disabled. And she's, sirolimus, I think she takes, or something like that. Sirolimus?
Like, I don't know what it's for. What are you talking about?
I have no idea.
Sirolimus, maybe?
Yeah, I don't know how it's pronounced, but she takes some medicine and she's got, for some tumor and with the tuberous sclerosis, and she has to get blood work done fairly regularly, I think. And so when she was up to 18 at Children's Hospital, they will do blood work under sedation. The day you turn 18, they will no longer do it under sedation.
Yes.
And her father was telling me that it's really been challenging because after they had like 3 or 4 security guards to restrain her, is there any way that you've come across or sort of institutionally to change those policies? I suspect the answer is no.
Well, we actually have been successful with some things, not with all. So this is, my part-time job, I feel like, is advocating for change at the adult facilities to accommodate things that are not common for them. And, that big picture, they're working on accommodating the majority of people, but we still need significant accommodations for this minority that have high needs. So we have been successful after literally years of getting sort of a plan in place. One of the major challenges that we had was with this small subset of people who were transitioning from pediatric to adult care who had portacaths that were in place because they were so difficult to get blood work from in pediatrics. And so they had been ordered by someone on the pediatric side. Someone on the pediatric side had continued to order flushes for maintenance through PMDU. And then after they turned 18, PMDU would no longer see them for flushes. And so then there was this whole, like, who's going to take care of this? And obviously that's Dr. Cassidy is going to take care of it because who else is going to take care of it? And so that was like a real challenge for a very long time where I met with so many people over such a protracted period of time. But we actually did eventually come up with a solution. And so now those patients are receiving flushes in the community through a specific stream through home and community care. And if they have challenges out there in the community, then they call my office, and then we have a mechanism to get them have their flushes, to get them to have their flushes through the VAST program, which is the Adult Vascular Access Program. But that took literally years. We have not come up with a solution for people to be able to have sedated bone mineral density scans. That's come up in our program quite a bit, where they would have sedated them to have those done as children. We know many of our patients are at risk of osteoporosis. And then on the adult side, sometimes we just kind of throw our hands up and we can never check their bone mineral density again.
Which I think is what happens a lot of the time with these kind of things.
Right.
People just give up and say, we can't do it.
So there definitely have been challenges. The sedation is probably the biggest problem that we have, because there's just not great access to anesthesia in various areas of the hospital for adult care. So something like access for the VAST program didn't require anesthesia, and so though it took years, we did come up with a solution. I run into it for ordering MRIs all the time. I don't know, Mary, if you experience the same challenge, but pediatric sedated MRIs happen twice a month at Victoria Hospital. It kind of ticks along. And they only happen once a month at University Hospital for adults. And then there's been MRIs down. And so even if I need an urgent MRI with anesthesia, I might get it in 9 months. Unless I send them to the emerge, right? Which obviously I try very hard not to do. So the anesthesia part is a real barrier. Sometimes our best luck is getting things done when they're sedated for dentistry. So if they're sedated to go and get their teeth cleaned, then we have had pretty good success in getting blood work done at the same time, and or x-rays even if we need them at the same time.
I did that with my son, as they took the blood work and tests and stuff. They wouldn't process it because the family doctor didn't have privileges.
So yes, and so that has been a problem with our VAST access. And so we've tried to navigate that. I think we have probably some better plans in place for that now than we did before. And you can always call me if it's a patient that I follow and I will order it for you. But that's even a challenge because sometimes I'm ordering things and then technically I'm medical legally on the hook for it, even though I don't know what I'm ordering because it's something that someone else asked me to order, right?
That shouldn't happen.
It's a quagmire. But I think if we all hold hands and put our heads together, I think there are solutions to these things. It's just that they aren't readily accessible and they require advocacy every time, which is almost impossible for primary care providers, right?
But the thing is, you and I can have a conversation and reach a conclusion.
Yes.
It's the unfortunate other pieces of our clinics.
Yes.
So I had an under 18 patient who needed blood work, could not get it done anywhere else, had to go to the hospital, and the hospital wanted me to write that there's no possibility of child becoming aggressive from the time they get off the vehicle and get onto that bed where they would be given sedation. I'm like, I can't do that.
No.
Oh, that's too much risk for aggression.
Yeah.
Okay, what do you want me to do?
Although I find the nurses in the PMDU usually are really good, like, I'm always, my expectation, whatever,
Yes.
is whatever I experience, whenever I have to talk with anybody in the hospital, my assumption is they're gonna say no, there's gonna be some complicated reason. And my experience with the PMDU is that oftentimes it's, what do we have to do to make that work? Depending
I
on
don't
who you
know.
talk to, which has always sort of staggered me.
I would say that is unusual on the pediatric side. I would totally understand that that happened to you on the adult side.
Yes. I wouldn't have complained if that was the adult side.
You'd be like, oh yeah, okay.
But are you suggesting that actually working with anesthesia directly may be a better route?
I think it can be, actually. I think that working with anesthesia directly on sort of these unique situations, I don't know that that's gonna result in like a clear path every time for these patients who need these procedures. Partially because there's so many pieces, right? Like you're not ever gonna be able to say anytime someone needs a sedated bone mineral density, you know, we're gonna have those on Tuesdays every other month because there's just not enough of them, right? But I think that in my experience working with anesthesia actually has been helpful. Speaking with them directly about like, this is a unique situation, this patient has unique needs and it's wrong for us to not meet them. And then that has led to productive conversations with troubleshooting. The challenge is just that it's time consuming every time.
There is, Claire Mitchell and I, a few years ago, were looking at having somebody come out to CPRI periodically to do blood work, and we're actually talking with an anesthetist who again really surprised me because he was really willing to sort of see how can we make that work, what do we have to do, what changes need to be put in place.
Yeah.
And so it's always nice to find people when you expect to find nobody
Right.
who's willing to make changes. So that makes a lot of sense as a way to go about it.
Yeah, I think so.
You mentioned that primary care developmental services. Is that guidelines, or is there a place in London, at the university, that has primary care for developmental services?
Ooh,
Is that just a
those are
guideline?
Those are guidelines.
That's a guideline.
I mean, you could answer better than I. I don't believe that there's anything in London that is
No, they don't.
specifically for primary care of an individual with developmental disability. Although I hope that maybe there could be one day. I know in Kingston, there is there's a +1 for primary care with developmental disabilities.
UI3 and family medicine.
And so that to me is so heartening. Like there's a movement somewhere that people have recognized the critical importance of this, right? And so I think that that's really positive. I think there are more of those developing in the States as well. And so I hope that that's a harbinger of more to come.
Case coordinators, could you describe, are they organized? Who do they report to?
In the CSCN, is that what you mean? The community, what does it stand for again? Help me out, Justine. Community Services Coordination Network or something like that? I can never remember. Yeah.
Something like that.
Okay, yeah. So that's totally outside of us. I've never worked with them directly. I've only worked with patients who are also receiving services from them. And so it's a unique sort of experience every time. So the families are able to contact them to say, you know, I need these services. And then they will get assigned this care coordinator who, in every experience that I've had with patients who are working with them, they have felt more supported by having them involved, as opposed to oftentimes I find that lots of our patients actually disclose that, you know, we refer them to this social worker and this physiotherapist and this whatever. Often they actually find that it's almost overwhelming for them. Like it's just another person who's going to tell me to call someone else. And there's another list of 3 forms that I need to fill out. And they actually get really overwhelmed when we refer them to all of these different services. I have not found that to be the case with CSCN. When they have that care coordinator involved, they find that person really keeps them organized and on track. So even if it is, you know, a paper that they need to fill out, because some of the papers we can't fill out for them, you know, they remind them, they call them, they say, have you done that yet? If you've done it, give it to me. I'm going to send it in for you. So they organize them and they orient them. And so in general, I have found that patients really think that's a really helpful experience.
In community living London, I think for people under 18, I think they have what they call family support workers who would generally serve the same purpose.
Yeah.
And I think I agree because they'll often attend appointments with people, sort of remind them, okay, we have another appointment next week with somebody else, we can talk to them about it. And it's also nice, I think, for families because it's somebody who's not emotionally involved in what's going on at the moment and so can sort of recognize other situations.
Yeah, and it's their job, right? Like,
Yeah.
I think a lot of times families feel guilty about not being able to keep up with all of this stuff, or they feel guilty about, we've had a number of patients who the families really felt guilty about transitioning their loved one into a care home, but they had such high behavioral needs or such terrible insomnia or all these different things. No individual who's also living their life at the same time would be able to keep up with all of those needs, but someone who that is their job and they clock in and they clock out, it's very reasonable for that not to be manageable for an individual human living their own life and providing care to other people in their families and, you know, managing all spheres.
Occasionally when the individual transfers into, say, a group home or something like that, I've seen it where the parents sort of suffered more than the client.
Totally.
And the client's thriving and the parents are having a
Absolutely.
withdrawal.
The separation anxiety, withdrawal for sure, and guilt.
Yeah.
And so we do a lot of trying to normalize this experience when we talk to families. This is not a failure. This is an appropriate step, right? Most people grow up and move out. Your loved one is growing up and moving out. They need more supports than some people who grow up and move out, but this is a normal experience, right? And this is not your failure. You are making a decision that is in support of your loved one. Interesting phenomenon.
Ashley, had a comment?
Yeah, Dr. Galloway, who was our first clinical fellow here,
Yes.
now works in British Columbia, and she made a comment that she's lucky enough to work at a clinic where they start at age 14 and kind of are responsible for that transition. I think in British Columbia, especially at UBC, they have a lot of resources.
Yes.
And so she said it's not her solution, but she's lucky enough to work at a specialized clinic.
I think it's a great solution, and BC, I think, has been a leader in this in many ways, like that on-track
Yeah.
resources that I showed there that were developed in BC really speak to the thought that their programs have put into this for years. Like on-track is not new. This has been around for a long time, and there's some really nice, easily accessible resources that anyone can use there. I think that's ideal, right? And as an adult provider, I'm lucky enough that I get to do clinics on the pediatric side as well. But as an adult provider, it's a rough go when we accept someone for the first time who are already adults who've not had any of this discussion as children. It's a rough go, right? Like they already kind of don't trust us. I mentioned that as one of the systemic barriers, right? There's a lack of trust in the adult provider. And when we start talking about things that they've never given any thought to before, like, you know, who's going to be your official decision maker if you can't be? What do you like? Advanced care planning? That's a really hard conversation if no one has had that conversation with them before. you know, these are tricky conversations, and they're smoother and better if they are introduced by the people they know and trust on the pediatric side. And this is like a hard thing for me as an adult provider to say to people who get that opportunity to do that, because I know you're already busy doing 100 other things. And so I don't have an expectation that you're gonna spend your entire clinic doing this, but if you can just introduce little nuggets here and there, like drop breadcrumbs as we're approaching that transition, I think it actually makes a huge difference to the patient experience and certainly to our ability to support them on the adult side.
No criticism to what you're saying, your population seems a lot cleaner and pretty straightforward than the ones unfortunately I work with.
And sorry, what population would that be?
Your developmental disorders, but intellectual disability, at least moderate or further worse, sort of inability to communicate, no sort of ability to take care of themselves, a lot more disabled.
So that would be actually the majority of my population.
Yeah, then I guess we're just seeing different people because we're dropping all these crumbs along the way. It's just like.
Totally, and you might be dropping them and they don't hear them, right? And we know that through all of medicine, right? Like we can tell you all this stuff about your COPD and then you leave and you don't remember 95% of it. And that's gonna be true every time. But the more we can reinforce it, or if we have some resources that we can actually send them home with, or some ideas that they can fall back on, I have no expectation that people are gonna come to me like fully prepared with their transition documents and like, hi, adult doc, I'm good to go, don't worry about it, everything's taken care of. I have no expectation of that. I don't think that that's fair or realistic. This has gotta be sort of a living, breathing process, and it has to be unique and different for every person. Some people come over really well prepared. Many people do not.
Are those websites available in English, or sorry, in other languages besides English?
Good question. The Star X one, I believe, has a Spanish version. I think that so on My Health Passport, there are some that are available in French.
Because more and more, and I think this is where it becomes trickier, I think what Sohail is saying also, with families that don't speak English, right? We have to have an
Sure.
interpreter, because then there's the nuances are
For
being
sure.
lost probably, and if
Huge
these
other
guys
issue, yeah.
aren't available in Arabic or Mandarin or whatever language, it's really tricky.
I think there's a push for that. So the transition queue on CanChild, I can't recall, but I know that they have worked on translating some of their other resources. So I can't recall if this one in particular is available in other languages, but there is a push, I think, to include more language diversity. Dr. Wells?
So I wanted to follow up to comment to this gentleman's suggestion is, I find so much commonality in your work, in my work.
Absolutely.
Even though they seem like totally disparate.
They are not.
So from advanced directives to everything you've said. But in my clinic, so one, even people with normal cognition, they only remember 17 to 20% of what a doctor tells them. So, and I work with mostly Alzheimer's disease, but all the dementia. So when they go home, I write their vital signs, I write their MMSE scores, and then impression. And then here's what we've agreed to today. One, you're gonna walk half an hour a day. You're gonna try to eat your vegetables. I'm gonna start this donepezil medication. We're gonna contact home and community care. They go home with it. Then when they come back for their follow-up, I have a copy of it. Okay, did you do your homework?
I think
So
that's such an important
It
point.
keeps them accountable, and so then they go to the registration desk, they make multiple copies. Okay, you have 5 children, your 5 copies for that, you're gonna make 3 copies. 1 if in case the dog eats it, 2 for your filing cabinet, and 1 for your refrigerator, so you walk by and read it every day. I mean, it's a little bit extra work, but I find it so valuable, so it takes me an extra 5 minutes in the clinic to handwrite it out. We need it paperless.
Yeah, that's the next
Do
thing.
you have a template to use?
Oh, actually, I do.
Can you email it to Sarah? Because I think it'd be incredibly valuable, because I've often thought, we spend a lot of time talking about the side effects of medications before people start them. And I would love to do a study where as soon as people leave my office, they're asked what the side effects of the medicine are, and I would bet they could say essentially none of them, probably.
Yeah, so I have a couple of templates. What I need to do is recreate it, because I'm tired of writing out Mediterranean diet for everything.
That's a long word.
I just want the stamp, Mediterranean diet. Keep your systolic blood pressure less than 150. Stamp. But yeah, so it's pretty generic, but I can send it.
That'd be good, it'd be really helpful to see.
When I was a resident, I think it was Dr. McDonald in endocrinology she had in her bag a package of cue cards. And everyone that she saw in the diabetes clinic, she would write a cue card for them with their new recipe for their insulin and their carbs and everything. Everyone got a cue card. before they left. And it's just such a valuable tool because they just don't remember. And I can't blame them for not remembering. Usually our appointments were like an hour. We talked about so many different things. What parts of that are they taking away with them? And what they take away may not be what I wish they took away.
Yeah, I just want to support it's a difficult transition. I have an adult patient and often they're nonverbal and they come into my clinic with their parents and they're traumatized. Like the look on their face is just horror because they've been going to, for instance, the CP clinic where there's orthopedics, pediatrics, all the therapists. Then they're seeing me and I'm saying, okay, now you're gonna have to see these 4 other people and we're gonna have to set up the appointment. Like it just, I mean, your clinic is of course the one I'm trying to get them all into, but often they now go from being in one place to being to 10 places. And it's so overwhelming and they just feel abandoned. I mean, that's the look on their face. And I think we have to do a better job of having clinics like yours that are more comprehensive, that have everything all in one place. Like I think that is really part of what the issue is too, is exposing them to it, but then having some sort of an equivalent on the adult side.
Yeah, I agree. And so as you know, we have now a joint clinic once a month with Dr. Debicki, who comes over and sees patients with me so that if they have, so that they don't have to go and have a separate appointment for their epilepsy, for example. And so that's really helpful. We don't have all the therapists in clinic, so that's a difference from the CP clinic. And that largely has to do with efficiency. So we have such small, our firm is small but mighty. We have very small FTEs of therapists who are dedicated to our service. And if we had them in clinic with us, that would basically take up all their FTE and then they wouldn't be able to provide any clinical service. And that consultative model does have a role, but not when there's no one to send them back to. So they don't have a school therapist that they're going back to anymore. So having a physiotherapist in CP clinic who can make suggestions back to the school therapist really works. They don't have a school therapist anymore. And so we have to have a therapist that they can actually go see for clinical treatment. And so we don't have them in clinic with us. Because there's so many patients that we see who don't need a physiotherapist.
That's right.
There's so many patients who don't need a social worker today, although probably all of them could use a social worker really. But we have to kind of make do with what we have.
Yeah, and I think that's one of the struggles, right, is that the funding models are not the same.
Yeah, very different.
I don't know if you remember, but Miriam Nouri in pediatrics set up sort of a tuberous sclerosis clinic.
Oh, I didn't know she did.
And it doesn't run very often, not as often as it should, but it's great because there is a neurologist, a cardiologist, a nephrologist, a dermatologist, and often a psychiatrist. And instead of, because I can think of one patient who, the family's in Windsor, they basically have to come to London every 2 weeks to see somebody.
Right.
And so now they can go somewhere and do one-stop shopping essentially. And it's also nice, because that means I can talk with a neurologist or a cardiologist about something and they can talk to me. And so I think it's a great model. Now, I don't know how you transfer that to adult care.
You probably can't. And partly that's because of remuneration, right? So partly, it's really challenging to get 3 different kinds of internal medicine specialists to come and do a half-a-day clinic because they'll only see 3 or 4 patients that day compared to, and that's not just remuneration, that's their own stress levels of their wait lists and all those different things, but it's not remunerative to come and work in that model of care. And that's a systemic issue that needs to be addressed.
It is, because we really believe in patient-centered care. And that's an ideal kind of model, especially for those complicated people who are going to be seeing a lot of different physicians or specialists of one kind or another. And I think it took a lot of work on Miriam's part to organize it.
I sure did.
And to sort of find the dates that people are available and stuff like that, but I think it really works well.
Yeah, absolutely. It's the ideal. So there's work to be done. But there are hopefully some useful takeaways from this, some resources that you can turn to, some ideas that you might have for yourself, like writing things out for your patients before they leave appointments. And even just thoughts that you might have, like maybe when they're 14, I'm just gonna say like, hey, one day you're gonna start seeing an adult provider, and just sort of laying those little bits of groundwork and reinforcing them time after time. So, any of those little baby steps in the right direction are a baby step further than we were before.
How do you manage it logistically? So when we see them up to the age of 18, then the next flock comes in.
Yes.
But when you've got them for the next 60 years, how do you just manage caseload size?
Great question. We are bad at it. So it's actually not gone too badly. So what we've done in the TLC program is, so we have myself and we have our full-time nurse practitioner, Justine, who's sitting up there, not to make everyone look at her. And so that has been invaluable, having the full-time nurse practitioner who has now developed her own expertise in this area and so is able to see patients independently. Our capacity obviously more than doubled because I'm not full-time in the program. I have, 5 or 6 different things that I do, as you heard in my lovely introduction. And so that has really sort of moved the goalposts for us because we can actually see more people in a more timely fashion. The reality is that many of our patients still don't have full life expectancies, full long-term life expectancies. Many of them do. But that, our 80-year-old patients are the minority, right? Like we have a tiny little tail of that older adult population. And the major influx that we had was when the program started. And that was what was most unpredictable, was all of a sudden this huge wave of people, especially from the community, where there had just been, all these primary care providers saying, like, I'm grateful. They were like, yes, let's send them all there. And that was great, but that was overwhelming. And there was no way for us to predict how many people were coming. We had no idea when we opened the doors to the program. Now it's more predictable because that major influx has slowed down. And so it does not really seem like it's getting ahead of us anymore. We're kind of catching up and we have this sort of steady stream that comes through from the CP clinic. And so now we can kind of see where we're at. We kind of know what to expect. And this seems like we can manage it from a medical standpoint. We would love to have more resources from an allied health standpoint, and we're still going to advocate for that loudly and routinely. But it gets to a point in a region where it kind of hits a steady state. That's been our experience with this particular patient population. Does that answer your question?
Yeah, that makes sense.
If no other questions, thank you very much for a very valuable presentation.